Alrighty. Hello, everybody. I am going to do your guys' last cancer review today. So I'm going to be covering oncologic emergencies and then going into like the specific types of cancer and what you need to know. Um, there's a lot for specific types of cancer. Like I have lots of notes, but I don't remember it being a super big topic on the exam, if that makes sense. I remember there being a couple questions, mainly like breast cancer. Like, there's one question I can think of for breast cancer. But I have a lot of stuff like bolded, so I'm just gonna go through and do like the important things. As always, if you guys have any questions, let me know. My plan is to get your HIV review up for you guys. That's the last video for this unit. I was gonna try and do it today, but I don't know if I'm gonna have enough time. So if I don't get it up today, then I will get it up Sunday night. I'm going on a float trip this weekend, so I will not be able to film it until Sunday if I don't do it today. That being said, if you guys have questions, if you email me, DM, text, whatever this weekend, there's a really good possibility that I won't answer until Sunday night. But by all means, I'm, still text me and whatnot, because you never know, I might be able to respond earlier. Without further ado, okay, so oncologic emergencies, you guys had a discussion board on this, which we didn't do, so I don't know if he went over these in class or not, but definitely need to know them. First one I have is superior vena cava syndrome. So this results from an obstruction. Usually it's from metastasis, of the breast or lung cancer. And basically what happens is it blocks the venous return of your upper vessels. And so you have engorgement. Signs and symptoms, definitely know these. I'm pretty sure we had a select all that apply for these, but you're thinking up above. So nosebleeds, facial edema, distended head and neck and chest veins, erythema, so redness in the upper body, and difficulty breathing. The nursing intervention for this, also really important, is high dose radiation in an emergency setting to relieve symptoms. But ultimately, you're worried about breathing in this instance, so you're going to put your patient in a high Fowler's position to try and expand their lungs. Like I said, I know we definitely had a question on superior vena cava syndrome, so I would know those symptoms and just kind of what you do. Spinal cord compression, pretty self-explanatory. It happens when a tumor invades epidural space, so usually from metastasis. But signs and symptoms, so new onset of back pain, weakness, numbness, change in bowel and bladder function. They might have neuropathy in their fingers, maybe even in their toes. As far as treatment, radiation and steroids, once again. Surgery, the surgery that we do for this would be a laminectomy, which is when you shave off part of the lamina in your back, and it essentially creates more room. And pain management and limiting activity. I have that and the laminectomy bolded. So you're worried about the pain, you're worried about limiting activity because you don't want it to get worse. Next one I have is third space syndrome. So this is when fluid moves from the vascular space to the interstitial space, and so you have edema. That's the big symptom with this is edema. Signs and symptoms are going to be of decreased cardiac output. So this is where you're going to have to take some of your knowledge from other units and apply it. So you're going to have hypovolemia signs and symptoms. So that might be hypotension, tachycardia, decreased urine output, things like that. So just know that. And then decreased treatment is fluids. That's the biggest thing you're going to do for this, rehydration, along with possible electrolytes and plasma protein replacement. So the example I have highlighted is albumin. But bottom line is third space syndrome is decreased cardiac output, so you are very worried about that. Next, I have SIADH. I also know I'm pretty sure all the questions we had about oncologic emergencies were select all that apply, which I'm sure you guys hate just as much as I did. SIADH, I know we had a select all on this as well. You guys have probably heard of this. It's symptom of inappropriate antidiuretic hormone. Basically, you're just having increase in antidiuretic hormone. So if you think about what that means, it's going to cause your kidneys to hold on to water. And so that's going to cause dilution of electrolytes like your sodium. And so basically your patient is going to become like hyponatremic. And so if you guys think all the way back to intro when you learned about the different electrolyte imbalances and just kind of like what that can do. So somebody that's hyponatremic, they're gonna have like, they could have personality changes, LOC changes. So like they might have a headache, they might be lethargic, nausea and vomiting. They could even have a seizure or go into a coma if it gets worse. Weight gain is going to be a big thing without edema because you're holding on to that fluid. Decreased reflexes, low urine output, headache, cerebral edema, that sort of thing. Treatment, so the biggest thing that I have highlighted for treatment, so normal saline, and then if you use a hypertonic saline, this can cause fluid overload. So if you were to use one of those, you would want to monitor it. They also might be on fluid restrictions, and they might be taking salt tablets to correct the sodium and water imbalance. So normal saline, fluid restrictions, salt tablets are all possibilities. And then they could also be on Lasix, but you want to remember with Lasix, it might cause even like worse electrolyte imbalances. So that's something to keep in mind. Okay, next I have hypercalcemia. I totally forgot there were so many of these. Hypercalcemia. So this is common in many cancers, but it's most often with breast, head, lung, and neck, because those cancers have a tendency to metastasize to the bone. So really you're going to see hypercalcemia with any type of cancer that metastasizes to the bone. And so your signs and symptoms are nausea, vomiting, anorexia, dysrhythmias, kidney stones, bone pain, LOC changes, and muscle weakness. Treatment is, so you might give them fluids, Lasix to get the fluid off and prevent heart failure. What I have highlighted is reduce the calcium that they're intaking, monitor their calcium, monitor their cardiac function, and monitor their muscle weakness. Those are the 4 things that I have highlighted. And then I also have a med highlighted. So the med I have highlighted is pamidronate, and so this is going to help take the calcium from the blood and put it back into the bones, and so that decreases the levels in the blood. And so this is a bisphosphonate, and I'm pretty sure any bisphosphonates end in that ATE. So if you see that, that's just going to be something that's taking that calcium from the blood and trying to get that back in the bone. Patients that have hypercalcemia, you're really worried about like movement, because obviously if all their calcium is in their blood rather than in their bones, they're going to have really weak bones and like just generalized weakness. And so that's why one of those 4 things was monitoring their weakness, because like these patients are the patients that might get out of bed and just like fall. Like they're at a very high risk for falls because of that lack of calcium in their bones. I mean, they don't have strong bones. So if you don't have strong bones, then you're at an increased risk for falling. Next, I have tumor lysis syndrome. Okay, so tumor lysis syndrome is a release of intracellular components related to the radiation and chemo that you're getting. So basically what's happening is as you're getting these treatments, your tumors are destroyed, and so the like internal components of the tumor cells just like burst open and then go systemic. And so you get this like imbalance of electrolytes. I'm pretty sure this was a select all as well, and it was just like, or maybe not a select all, but it was a multiple choice, and it was like the like multiple options within the same answer choice. So you're gonna have increased uric acid, increased phosphate, and increased potassium. Those are like the 3 things that I have highlighted. And so signs and symptoms, you know, like nausea, vomiting, diarrhea, weakness, and muscle cramps. As for treatment, you're going to want to treat each of those imbalances. So think back to your hyperkalemia treatment. So that's your C-big-K dye. So make sure like you guys remember what that stands for. So that's going to be your calcium gluconate, which is calcium gluconate, Sodium bicarbonate. So remember, sodium bicarb is used if you're acidotic to help with breathing, and then calcium gluconate protects the heart. C I is insulin, and then glucose. Insulin is really rapid at putting potassium back into the cells. C big. K oxalate. Remember, that's like the Lasix. It's basically, like Lasix, but for potassium. So it just increases the excretion into your stool. So you want to monitor bowel sounds and then make sure that they're free from breakdown from frequent passage of stools, and then dialysis. But you're probably not going to do dialysis with these patients unless they have a kidney issue. This can lead to AKI because of the uric acid crystallization in distal tubules. So remember, with uric acid, we're going to use, what is that med called? Allopurinol can help to decrease that. Next, I have cardiac tamponade. So this is fluid around the heart and in the pericardium. So signs and symptoms would be like distant heart sounds, shortness of breath, tachycardia, might have a cough, anxiety. Treatment would be surgery to create a pericardial window, or you might even place a pericardial catheter. You're going to want to support these patients with like O2, IV fluids, and vasopressors. Next, I have carotid artery rupture. So this is invasion of an artery by tumor or erosion following surgery or other radiation. And so I remember this being a question. So this is with head and neck patients because the radiation, because your carotid artery is like right here. So if you think about it with like, if you're getting radiation to the head and neck, that puts that artery at risk. And so with head and neck patients, and basically what you could have happen is your carotid artery just like becomes so weak over time that it just like ruptures and it oozes and spurts blood. So if you see this, you automatically want to apply pressure. That's the first thing you want to do. And I believe that was our question on the exam, is like, you see a patient and they have blood spewing out of their carotid artery, what do you do? So you want to make sure you apply pressure and then administer blood products as needed along with fluids to make sure they don't go into like hypovolemic shock, and you might even have to do surgery. And then lastly, for oncologic emergencies, I have just like in general hematologic problems, which we have literally talked about so many times. But remember, when you get like chemo and whatnot, it can cause pancytopenia, so just like decreased amount of all your blood cells. So you might have anemia, you might have thrombocytopenia, neutropenia, like there's just a ton that you can get. You might have, sorry, I thought that was important. Neutropenia, thrombocytopenia, anemia. They are at a bleeding risk, so you want to decrease the amount of sticks you do with these patients, be gentle, and give them electric razors. They might also get DIC, so that's when like they use up all their clotting factors in one area and they start to bleed in another. This is seen a lot with leukemia patients. And so your treatment for this is to make sure they're on those bleeding precautions that I just talked about. You might give plasma with clotting factors. Heparin can slow the clotting cascade if they have DIC, and so that can help to prevent them from like bleeding out in another place. And then there's also those meds that we talked about. So like Neupogen would be for neutropenia, and then Epigen, I believe, is for anemia. I'm probably saying that wrong because, as you guys know, I cannot pronounce meds. So yeah, so that is what I have for all of your oncologic emergencies. I mean, that's literally it. Not too much. So I would just make sure you kind of know like the general signs and symptoms, because like I said, I remember having a select all on like SIADH, and then I think it was tumor lysis. I would know like what you would do in an immediate instance. So like with carotid artery rupture, apply pressure. and then know the meds where they're applicable. So like the C big K dye with tumor lysis syndrome, the bisphosphonates with hyperkalemia, or not hyperkalemia, with hypercalcemia, and then just knowing like the meds with hematologic problems. So that is everything for that. So now I'm going to move into the different types of cancer. I'm just like overwhelmed looking at my notes, but I know that there was not that much on this exam. So, okay, so skin cancer is the first one that I have. Skin cancer, you guys, obviously we've heard about skin cancer all the way back from health assessment and probably before. Biggest thing I remember on the exam with skin cancer is the ABCDE. So I know that E we've learned as different things. I can't remember what we learned it as in Gurley, but I know that for Schneider, I have evolving as that. So like I have asymmetry, border, color, diameter more than 6 millimeters, and evolving. So I would know that ABCDE. I don't really remember anything else about skin cancer being on it. I mean, you guys know skin cancer, like prevention, wear sunscreen, don't go out at the sun when it's like the peak of day. So between like 10 and 2, wear like long sleeves, wear a hat. I do have a couple of individual types of skin cancer, but I'll go over it, but I don't really remember it being on the exam. So melanoma is obviously like the most deadly. That's when you have like the irregular shapes and borders. You might see ulcerations, cracks, bleedings, and melanoma can rapidly metastasize, so that's why it's pretty deadly. Basal cell is like the small waxy nodules, so they're like superficial blood vessels. They're very well defined, ulcerated, and red, and they have the ability to invade nerves, bones on rare occasions, but they have a high recurrence rate. So basal cell is the one that like you might get frequently like over time. Squamous is the scaly rough lesions with a central ulceration. They might be bleeding, crusted, and eventually metastasize. And then actinic keratosis is precancerous white crusty lesions like on the head, back of the arms in older patients, and they can turn into cancer. So usually we freeze these off in an outpatient setting. Like I said though, I don't really remember there being much on skin cancer other than like ABCDE, knowing that. Next one I have is oropharyngeal cancer. So etiology, I don't think there's really anything important there, but it's usually in men and patients over 40. And like head and neck squamous cell carcinoma is the general umbrella term. So the 3 risk factors that I have highlighted are tobacco, alcohol, and poor oral hygiene. So I would remember those 3. Other ones might be like herpes, syphilis, sun exposure, mucosa irritants. Diagnostics for all of these are pretty much the same. You're going to do like an H&P, you're going to look at a biopsy, CT, MRI, PET scan, anything that you need. Signs and symptoms, I have a couple of these highlighted. So I have like leukoplakia, which are the white patches, and then erythroplakia, which are red blotches. You could have ulcerations on your lips that are bleeding, sore throat and mouth, voice changes, slurred speech, increased salivation, dysphagia, difficulty swallowing, pretty much anything with like the mouth you can think of. Treatment, surgical removal is one option. One thing to remember though is if they do get surgical like removal, they are probably going to need an NG tube after surgery because they're going to have trouble like swallowing and eating. And so you want to make sure that you're focusing on nutrition. Pretty sure we had a question on that. And they also might need parental nutrition, like that parental nutrition for the first 24 to 48 hours. So that is like the biggest thing that I would remember with oropharyngeal is that they're going to need an NG tube for the first 48 hours. Head and neck cancer is usually treatable if it's detected early, but if it's spread, the treatment rate goes down. And like it spreads to areas beyond the head and the neck, then like it cannot be cured, and the focus is on improving quality of life, which is really sad. So next is esophageal cancer. So we don't really know what causes this, but some potential risks would be like tobacco, excessive alcohol, Barrett's metaplasia, which is chronic inflammation from GERD. Okay, hold on, my computer is about to die, so I need to go get my charger. Okay. Esophageal cancer. I don't remember what I've said, but we don't really know what causes it, but there are risks like tobacco, alcohol, obesity, that chronic inflammation from GERD that we talked about. I remember in patho, Barrett's esophagus. And usually esophageal cancer is pretty advanced when we find it because it's usually like in later stages. Signs and symptoms would be like pain in the later stages. If you have a really large tumor, it can actually like obstruct, and so that could cause problems with eating, problems with breathing. And so if you have problems with eating, then that can cause weight loss. Diagnostic, there are a couple different things with esophageal cancer that you can do that you can't do with others. So that would be endoscopic biopsy, endoscopic ultrasound, and then a barium swallow can detect like how narrow your esophagus is. Moving on to colorectal cancer. So colorectal cancer is a pretty big one. So risk factors, males are like more likely to get this than females. Obesity, smoking, alcohol, and large intake of red meat. Signs and symptoms, rectal bleeding, blood in the stool. So you might use like a fecal occult test to look at that. Bowel habit changes, abdominal tenderness, ascites, hepatomegaly, fatigue, and weight loss. So diagnostics, colonoscopy is the golden standard, and a biopsy of any suspicious areas might be taken. So I have that highlighted. Obviously, that's one of the reasons why we do a colonoscopy or like a sigmoidoscopy. Might also do a digital rectal exam, like I said, a fecal occult blood test, and the screening for a colonoscopy. I think I already mentioned this, but it's age 50 unless something is found. So, like, yeah. And then it's age 45 for African Americans. So, some nursing interventions for colorectal cancer. Okay, so first off, you would want to educate your patients like before about how like exercise and healthy diet of fruits, vegetables, decreased intake of red meat can help prevent colorectal cancer. Also, if you have a patient that is getting a colonoscopy or like a sigmoidoscopy, you're going to have to educate them on the prep that they're going to have to do. So if anyone's ever had a colonoscopy for some reason, like, you get like the go heavy, or no, go lightly. Sorry. It's called go lightly, but like it's not go light. It's called go lightly, which I think is kind of ironic, but basically it cleans you out. So you're going to have to educate your patients on that. And you also might not be able to do these types of tests on patients if they have a cardiac history. So those nursing interventions, we're going to ID high-risk patients, educate on prep and post-op care for like if they have an incision site, drains, dressing changes, ostomy. So that would just be like educate on your signs and symptoms of infection, dehiscence, anything like that. Monitor the skin for healing and infection, just said that. Might have sexual dysfunction. Wound ostomy nurse and support groups can be helpful. Ultimately, we're aiming for normal bowel elimination pattern with feelings of comfort. So that is colorectal cancer. Another big one I have is pancreatic cancer. So this has a high mortality and most tumors are in the head of the pancreas. As far as your risks go, it increases with age and peaks around like 65 to 80. So this is definitely a cancer that affects more like the older generation. And usually like diabetes, chronic pancreatitis, and like smoking or like a family history are like the risk factors for this. Signs and symptoms, it's found a lot later, most of the time. So like there's not usually symptoms, but If there are, it would be like a dull abdominal pain, extreme itching as it progresses. I have that highlighted, so I would remember it. Rapid weight loss is also a really big one, and pain in the upper abdomen that can radiate to the back, along with a lack of digestive enzymes. Do your regular diagnostic tests. So nursing care, I have this highlighted. It's usually palliative and not curative because, like I said, usually pancreatic cancer is found too late to be cured. And so like the main priority is just going to be like helping patients stay comfortable. Managing their pain is a priority. What else? You're going to want to monitor their blood glucose along with like administering insulin if you need. They might need enzymes with their meals. And the surgery that I have highlighted from this, which I think we had a question about, maybe, I don't know, was the Whipple. So basically what this does is it removes the head of the pancreas and then the remaining organs are attached to allow a person to digest. So another thing is to make sure you manage depression with these patients because, like I said, it's usually a poor diagnosis, so that can cause a lot mentally. Next, I have renal cell carcinoma. Biggest risk factor for this is smoking. That's what I've highlighted. Signs and symptoms, it's usually not detected in the early stages, but some might be like hematuria, flank pain, a palpable mass, weight loss, fever, hypertension, and anemia. Diagnostic wise, like an ultrasound is used a lot of times because this can differentiate between tumors and cysts. And that's all I have. Okay, bladder cancer, I remember there being several questions on, so I'm gonna talk about that. Okay, so one of the most malignant tumors is transitional. Okay, that's not important. Etiology, remember these. Smoking, exposure to dye. I remember smoking being the one on the exam. It was a question and it was like, I don't remember. I just know it had something to do with smoking and bladder cancer. Signs and symptoms are gross, painless hematuria. Remember that. That's your biggest symptom. Other things might be like frequency and urgency, bladder irritability, painful urination. I have this highlighted, I can't pronounce, cystoscopy and biopsy is the most reliable test for diagnostics. Remember that. So treatment-wise, you can remove part or all of the bladder. So a patient might need a urinary diversion, open loop resection, intravesical therapy. I have this highlighted as well. Intravesical therapy is when you instill chemo in the bladder for 2 hours and then you reposition them for every 15 minutes. And you do this for 6 to 12 weeks. And then I also have this whole thing highlighted, so remember this. This is post-op care for a loop resection, which is one of the procedures that you can have done if you have bladder cancer. So post-op care would be drink lots and lots of fluids. Large red blood clots are normal, and rust-colored flakes in the urine are normal. I remember that being on the exam somewhere. Take opioids for pain, sitz baths for muscle relaxation, and encourage smoking cessation. So that is what I have for bladder cancer. Next is lung cancer, which is also a pretty big one. So lung cancer is obviously highly associated with smoking and tobacco exposure, even secondhand, and African Americans are more likely to die for men, and women are more likely to die for like Caucasian. So Caucasian women and African American men are like the most common. Pollution, radiation, asbestos, that can also be a risk. So signs and symptoms, once again, not usually apparent until late stage, until it's metastasized, but I have this highlighted. It's going to present as lobar pneumonia that doesn't resolve. So that would be like cough, blood-tinged sputum, dyspnea, unilateral wheezing, and they're going to lose weight and be fatigued over time. Diagnostic wise, you're going to do all your normal diagnostics, but a bronchoscopy is going to be like the special thing for this one. And you want to teach your patient that prep is you have to be NPO and you have to get their consent. Nursing intervention, you're obviously going to monitor their respiratory status. So this might be like putting them in high Fowler's position, monitoring those ABGs, smoking cessation. And then since these patients can lose a lot of weight, you want to maintain a high calorie and protein diet, turn, cough, deep breathe, incentive spirometry, range of motion exercises because they're going to be in bed a lot. If they have surgery, you're going to want to do, like I said, turn, cough, deep breathe, and IS, pain management. And then one thing I have is positioning. So if they have a total lung removal, you're going to have the operative side down. And then if they have just like partial, then they can be in semi-Fowlers. And you want to maintain a chest tube if they have that. As far as screening goes, so patients who have a 30-year PAC history or currently smoke are ones you're going to want to screen, along with ages 55 to 80, or those that quit less than 15 years ago, and you're going to screen them with low-dose CT scans. And also make sure you know that the number of PACs per day times how many years they smoke that's their PAC year history. That's very important. That will be on the exam somewhere. So number of PACs per day smoked times the years is PACs per year history. I also have something about Pleurex, which is used when there's like fluid accumulation in the lungs, which is very common with lung cancer. So basically what happens is a catheter gets put to drain the fluid. And so patients can usually go home with these and like do it on their own. And it's typically like PRN just for symptoms as they need it. It's a clean procedure, as clean as possible. Roller clamp allows you to speed or slow down drainage. And what this does is it's just a really good method to help prevent patients from coming back and if they have severe shortness of breath. So that is all I have for lung cancer. Okay, so next I have brain tumors. Brain tumors, brain is a frequent site of metastasis, and it can be primary, like you can have a primary tumor in the brain, but it's more likely to be secondary. Signs and symptoms, like we talked about with like stroke and ICP, it just depends on the location of the tumor and how big it is and like what it's pressing on. So just think back to like your general neuro symptoms. So that could be like nausea, vomiting, headaches, seizures, memory problems, mood changes, sensory loss, speech changes, anything like that. Diagnostic wise, we're going to incorporate a neuro exam along with an EEG on top of all those other things. So treatment is surgical removal of small tumors because you want to decrease their ICP and relieve the symptoms. You might also place a ventricular shunt to relieve excess fluid, and then also like chemo and radiation. Nursing interventions, the biggest thing I've highlighted is to monitor for ICP. So remember that a change in LOC is your earliest indication of increased intracranial pressure. Assess their baseline LOC, monitor for confusion and behavior changes, ensure safety. So these patients are going to be on fall precautions, have the yellow socks, the yellow wristband, monitor and treat for seizures. So know your seizure precautions. So like having the padded side rails, oxygen at the bedside. Don't restrict them, turn them on their side. Communication might be an issue if they like have slurred speech and stuff, so you might need like a communication board. And you might need to intervene with nutrition, so like you might need like TPN, for example. That is what I have for brain tumors. Like I said, there's a lot, but I feel like you guys will be good. Okay. Next is bone Yeah, bone tumors. So bone tumors are relatively rare. Usually, if bone is affected with cancer, it's from metastasis, but patients can have them, obviously. So we have a couple different types. So we can have benign bone tumors, so like osteochondroma. So this would be like a painless, hard, immobile mass. You might have a lower height than like your normal age range, or like a limb length discrepancy, pressure and irritation. And if you have a benign bone tumor, you're not going to do anything to treat it unless it becomes symptomatic, but you're going to have regular visits. And obviously, if it becomes symptomatic, then we're going to remove it. Malignant bone tumors would be like osteosarcoma and metastatic bone cancer. So that would be like in the bone, muscle, fat, nerve, or cartilage. And like osteosarcoma is a really common one during childhood and young adulthood. I believe you'll talk about it in peds. I can't remember. But signs and symptoms, so it aggressively metastasizes to other sites with excessive pain and swelling, especially around the knee. In treatment, you usually want to do chemo before surgery to shrink the tumor and try to save the leg. Diagnostic wise, tissue biopsy, all those normal things. One thing with patients that have bone tumors is they might have pathological fractures. So you're going to look for increased serum calcium. So you're going to look for hypercalcemia, and your treatment is pain management and fall prevention, preventing fractures, and managing that hyperkalemia. So remember, we talked about those bisphosphonates, which are anything that end in the ATE, and those are going to help move calcium from the blood back into the bones. You're going to want to help them with ambulation. So just because these patients have hypercalcemia, I don't know why I keep saying hyperkalemia, does not mean that they're going to be on bed rest. And that's very, very important to remember, is you still want to help them with ambulation, and you still want them to ambulate, because ambulation can actually help to like increase the calcium in your bones, and it can actually help your bones to grow stronger. So that's really important. I remember we had a question on that, but I don't remember if it was this exam or if it was musculoskeletal. Okay, so these last couple are breast cancer, leukemia, lymphomas, and multiple myeloma. I remember these, I have all 4 of these highlighted, so I'm pretty sure that they're important. Okay, we're going to start with multiple myeloma because it's the shortest. Okay, multiple myeloma is cancer of the malignant plasma cells. So remember, plasma cells are found in the bone marrow, and they're part of your immune system. And so what happens is these plasma cells start to produce antibodies that are just like ineffective and really harmful, and they're made up of Bence-Jones proteins. And so what happens is they then destroy the bone and they become harmful. And so if you don't treat multiple myeloma, it becomes very fatal and you can die within like 2 years. Etiology, it's possibly caused by genetics. We don't really know what causes it, but it's more in men, and it's usually above 40. You're usually above 40 when you discover it. So what happens is infiltration of bone marrow, we already talked about with the malignant plasma cells, and so we have excessive amounts of immunoglobulin proteins and cytokines, and so these are like what I just talked about, and these destroy the bone, kidneys, spleen, heart, and liver. So signs and symptoms, I have all of this highlighted, so I remember this. So we worry about the kidneys the most with Bence-Jones proteins, and so these can actually be found in the urine. And so we want to monitor their INO, urination, and provide adequate hydration and monitoring of kidney function. Very important. I remember we had an exam question on that, so I'm going to say it again. So signs and symptoms of multiple myeloma, we're worried the most about the Bence-Jones proteins attacking the kidneys. So we're going to want to examine the urine for them, monitor eyes and nose strictly, and encourage urine output with frequent hydration and adequate hydration. You're also going to monitor those kidney labs of the serum creatinine and the BUN. Other signs and symptoms, so bone pain can result from hypercalcemia, because remember, all of the calcium then is in the blood rather than the bones. So you have really weak bones that can hurt when you walk. Ribs, pelvis, and spine are the most common sites of skeletal pain. Diagnostic wise, like I said, we're going to look at the urine, might look at the bone. And if they have a decreased albumin, that's usually a poor prognosis. Nursing interventions. This is where that is. I knew this was on this unit somewhere. Okay, so like I said, if somebody has like weak bones, whether it's from like hypercalcemia or from bone cancer or whatever, that does not mean that we want to keep them in bed and limit their ambulation, because careful ambulation can actually help, because bearing weight on bones can help reabsorb calcium. That is super, super important. I know we had a question on that, and I know a lot of people missed it. So I would just remember that just because you have weak bones from like multiple myeloma or hypercalcemia does not mean that you want them to stay in bed. You want them to get up and bear weight on those bones, because that can help reabsorb the calcium back into the bones. Like I already highlighted with multiple myeloma, we're really worried about the kidneys, so adequate hydration is the other thing. So really want to monitor those fluids, get them on IV fluids if needed. And then the other thing is fall risk, and so safety. So I would say with multiple myeloma, the three biggest things are ambulation, hydration, and then like fall risk / safety management. So like you want to be careful with transfers to prevent fractures. You might do like pain management, and then osteoporosis drugs are common. So we already talked about some of these. So like pamidronate, for instance, or zoledronic acid, iticdronate, those all inhibit bone reabsorption without inhibiting bone formation. So that is what I have for multiple myeloma. Next, I have lymphomas. So lymphomas are malignant neoplasms in the bone marrow and lymphatic structures. So this is a cancer of the lymphocytes and the lymph nodes, and it can metastasize to literally anything. So many patients, because this is a cancer of the lymph system, they're going to have enlarged lymph nodes in the head and neck. There's two types of lymphoma. So we have Hodgkin's and we have non-Hodgkin's. So Hodgkin's is one of the most treatable cancers, and there's like two general like age populations with this. So it's usually in teens and young adults, and then adults in their 50s. And so this is the one that has the Reed-Sternberg cells. So I would remember that. The Hodgkin's has the Reed-Sternberg cells. And so these are multinucleated cells. I remember from patho, Gerald's telling us they look like owls. I don't know why. Etiology is pretty unknown. So clinical manifestations, like I said, the biggest one is they're going to have enlarged lymph nodes, usually in the cervical, inguinal, and axillary areas. They might have weight loss, fatigue, fever, chills, fever, night sweats, weight loss, and fatigue. Those symptoms have a worse prognosis. So you're going to monitor blood labs, might do a lymph node biopsy. Nursing interventions. So aggressive treatment is usually like used because, like I said, this is pretty treatable if you catch it. So you're going to want to monitor those side effects along with they're at a really high risk for infection since the lymph system is involved. So just like monitoring for infection. Next is non-Hodgkin's lymphoma. So this is malignant neoplasms of the T cell and B cell origin, most common in men and older adults, but it can happen in all ages, and it's the most commonly occurring hematologic cancer. So this one does not have the Reed-Sternberg cells, but basically with this cancer, you have lymphocytes that are in just like all over in terms of stage of development, so they're not all effective and useful to the body. So once again, we have unknown etiology. Clinical manifestations are pretty much the same when it comes to like fever, night sweats, weight loss. Aggressive forms respond to aggressive treatment. We might have fertility issues and just like pain management is a key with this one. I don't really remember too much being on the exam about lymphomas. If anything, I would know like which one has the Reed-Sternberg cells, and I would know just like the lymph node enlargement, that sort of thing. Next, I have leukemia. So leukemia is a group of malignant disorders that affect bone marrow, lymph, spleen, and the blood. They're all related to white blood cells or the creation of white blood cells. And so basically the cells become not functional, and then they invade and destroy bone marrow, potentially moving to the liver, spleen, lymph, brain, and testes. Once again, etiology is unknown. Risks could be like viruses, radiation, chemo. Really, viruses like and radiation and chemo are risk for like everything. Clinical manifestations are bone marrow suppression. So this is where you're going to see that pancytopenia. So they're going to be anemic, thrombocytopenic, and then neutropenic, and at a really high risk for infection because the white blood cells are just like not functioning properly. Diagnostic wise, monitor their blood labs. So there's a lot of different types. So we have AML, ALL, CML, and CLL. I don't really remember him getting like too specific on the exam. One thing I do have noted is like the chronic, so the CML and the CLL, they have a more gradual onset with more mature white blood cells, and so this is like the better form. ALL has a better prognosis for kids, though. CLL is the best one to have, so if you're going to have any of these, you want to have CLL. And then also I have ALL is the one that has the Philadelphia chromosome, but like I don't really remember him getting too specific. All the signs and symptoms are very similar. It's just like because of the anemia, thrombocytopenia, and neutropenia. So like they might have bleeding, fever because they have infection. There's a stupid fly in here. So monitor for like bruising, lots of like infection risks, low platelets, low everything. So keep that in mind. Treatment, the goal is to eliminate the bad cells, and so you want to focus on obtaining remission. Chemo is based on a couple different things, but that's how it is with like every type of cancer because there's so many different chemo drugs. You might do combination therapy with radiations and corticosteroids. You might do a stem cell transplantation for aggressive, and you want to make sure that, like I said, you're keeping them on bleeding precautions, infection precautions, and just like monitoring who they're around. And lastly, I have breast cancer. Breast cancer was a huge part of, like, I would say if there's one cancer that you need to know, like, really, really well, it would be breast cancer. Okay, so breast cancer is the second leading cause of cancer deaths in women. So risk factors are above 50 years of age, family history, personal history of breast, colon, endometrial, or ovarian cancer, early menarche, or late menopause. So basically girls that get their period earlier or go into menopause later are more at risk. If you have a full-term pregnancy after 30 years of age, the BRCA mutations, and then Jewish women of Eastern European descent. So prognosis for breast cancer is determined by size, axillary node involvement, tumor differentiation, human epidermal growth factor receptor 2 status. I don't even know what that is. So prognosis is determined by lots of things. We have a couple different types of breast cancer that you need to know. So I have DCS, which is localized breast cancer of the ducts that do not invade surrounding tissue, generally doesn't have the ability to metastasize, and it's usually unilateral. IDC, so this starts in the duct and then invades surrounding tissue, and so it's different than the DCS. Big thing with this is the orange peel skin with a lump and dimpling. Remember that. I would really, really remember that because I think we had a question on that. And also, this can invade the bone, lung, brain, and liver. I would also remember that. Paget's disease is a rare form of breast cancer that starts in the nipple and goes to the area surrounding it. So signs and symptoms, I have all of these highlighted, are itching, burning, bloody nipple discharge, and superficial erosion and ulceration. Usually this shows there's an underlying condition and it goes unnoticed a lot of times because it's misdiagnosed as infection. I would remember that. Inflammatory breast cancer is the most malignant form of breast cancer. It's rare but very aggressive, and it's once again also usually misdiagnosed as infection because the breast looks red, swollen, and thick like an orange because the cancer cells block the lymph channels. And it's also missed on a mammogram a lot. So I would remember all those types because I know we had questions about like I said, I know we had questions about the IDC with the orange peel skin. And then I know we had questions with Paget's over like the bloody nipple discharge. So other than those signs and symptoms with those specific types, other just like generic signs and symptoms for breast cancer would be hard, irregular shaped, poor delineated, non-mobile, non-tender nodules. I would remember that. A small percentage can cause nipple discharge, but it's usually unilateral, clear, and bloody if you have it. You could have nipple retraction, and then that pudorn, d'orange, pardon my whatever language that is, probably French, but that's like the orange peel skin that we talked about. Diagnostic wise, so breast self-exam should be done at the same time each month because this is how women are going to best detect breast cancers by feeling for lumps. One thing that's really important that you want to educate your patients on is that when they do a breast exam is to do it at the same time every month because your breast can feel different like leading up to your period and when you're on it. I believe the general rule of thumb is to wait 2 weeks until past menstruation to perform this exam. And then also obviously like using a mammogram. Collaborative care. So single most powerful prognosis factor is the presence or absence of malignant cells and lymph nodes. That's really, really important. So basically like depending on if the cancer has invaded lymph nodes, it's going to depend on like how good or how bad your prognosis is. And then chemo, radiation, all those therapies we've talked about can be used. There's also a mastectomy, which is pretty common for women with breast cancer, and it's a removal of breast, pectoral muscles, axillary lymph nodes, all fat, and adjacent tissues. This used to be a standard of care, but now there's like more treatment options, so we don't use it as much. So like you could do breast conservation, which is removal of all of the tumor with a margin of normal tissue left. We have modified radical, which is like just removal of the breast and axillary lymph nodes, but it preserves the pectoralis major. So like lots of different options, but mastectomy is still used today with a lot of patients. One thing I've highlighted, which I think was on the exam, is that patients that have a mastectomy are at an increased risk for lymphedema because the lymph nodes are removed, and so the fluid that normally goes here accumulates, and so it accumulates in the arms and like the soft tissue. So things to remember, all very, very important. I know we had to select all that applies on a mastectomy, like nursing interventions that you would do for a mastectomy. So all very important is you want to monitor for numbness in the arms and fingers because that could be an indication of a complication. No sticks or blood pressures in the arm that is associated with the mastectomy, and they need to be very protective of it from sunburns and injury because just like hitting this arm can cause it to flare up. Anything can cause it to flare up. You can put the compression sleeve on them to help maintain lymph movement. And there's also a special massage they can do by OT to try and mobilize the arm for therapy. So like I said, no sticks and BP in that arm. So you're going to want to like put a sign on like their bed or on the wall above the bed. Post-operatively, you're going to place them in semi-Fowlers with the arm elevated on a pillow, either at or above heart level, and you want them to start flexing their fingers as soon as possible, and then they can eventually start doing exercises like running their fingers up a wall. You want them to do that as fast as as quickly as they can after surgery, because you want to maintain proper muscle tone and blood and lymph circulation. Like I said, we want to teach about reducing lymphedema, so like nothing on the affected arm. Bandages are not used early in post-op period, but they will have a dressing of some sort, and so we want to protect that arm from minor trauma and report any like inflammation. You want to administer analgesics 30 minutes before any of the exercises that they do, and use warm water with showers to have a soothing effect while decreasing joint stiffness. So I would go through and make sure you know like all of those nursing interventions that I talked about, because I know we had a select all on them. So like I said, using like the compression sleeves on the arms, flexing your fingers, running fingers up a wall as soon as you can, but especially the flexing fingers. Semi-Fowlers, they're gonna have a dressing of some sort, so like maintaining the dressing, that sort of thing. We can also do a lot of other therapies for cancer, like in conjunction. I don't remember anything about that. Last two things here are psychologic care and mammoplasty. So psychologic care is obviously we want to never lie or give false hope to this really any cancer patients or any patients, but we want to encourage them to verbalize their anger and fear. So I'm sure you guys know the whole like tell me more, like that's usually the common answer on nursing exams when it comes to communication questions. And we wanted to develop a positive and realistic attitude with these patients and help them to identify sources of support and strength. We want to promote open communication, offer information about community resources, and we never want to deliver a diagnosis ourselves. It should always be done by an MD. And finally, mammoplasty is a breast reconstruction that can be done. So just note that that is an option for breast cancer patients. Alrighty, that is everything. Like I said, it's kind of a lot. I would say with the types of cancer, just like knowing, knowing all of your breast, oh my gosh, I lost my train of thought. Oh, all of your like mammoplasty, like nursing interventions for post-op, I would definitely know those. I would know your interventions with bladder cancer, with like the loop procedure, and know that smoking is usually correlated with bladder cancer. I would know about like colorectal screening. Yeah, so that's kind of like the big things that stick out to me. Obviously, I make this disclaimer whenever I do any of your videos, but like anything is fair game. So I would just like go through and like skim over the textbook. I'm not telling you guys to go and read the textbook because I didn't read the textbook, but I did skim over things usually like the night before the exam. I would just go through and like skim the tables, like the diagrams and stuff. If you're going to read the book, I would do like the diagrams and the tables and stuff, because that usually has the more important information, not only for Schneider's class, but definitely for BEST as well with peds. So yeah, that is everything that I've got for y'all. Like I said, be looking out for that HIV review video. I can already tell you I'm not going to be able to get it up today, but I will get it up Sunday night at some point. So that should give you guys plenty of time to watch this video along with the other cancer one. That way you just have to watch one more video. If you have any questions, don't hesitate to reach out to me. You guys are going to do great. Just think, after this exam, you only have one more left, and then you're going to be a fifth term student like me, who just like does nothing. But anyway, have a good weekend, guys, and let me know if you need anything.